Evening, everyone. Thank you, Clarnet and Rimpa, for this platform. And on behalf of Madhya Pradesh Ophthalmic Society and Ocular Trauma Society of India, I warmly welcome you all on this first Central Zone academic collaboration, an important step taken by our President, Dr. Puren Bhasin, in strengthening the regional academic engagement in ocular trauma. We are honored to have eminent panel experts with us today, stalwarts in the field of ocular trauma and ophthalmology. We would like to welcome respected Dr. Ashok Grover, sir, Dr. Dr. Mohan Rajan, sir, Dr. Dr. Rajan, sir, Dr. Namrata Sharma, madam, Dr. Hunavar, sir, Dr. Puren Bhasin, sir, Dr. Mehul Shah, Dr. Jayanta Das, Dr. Pawan Sthapak, sir, Dr. Shakeen, sir, and our scientific committee members from MP State. So for the opening remark, I would like to call upon our President, MP State and Ocular Trauma Society, Dr. Puren Bhasin, sir, for his opening remarks.
Thank you, Shweta. And at the outset, I would like to thank all the OTSI stalwarts and my predecessors and the All India Ophthalmic Society incoming president, past president, Dr. Natarajan, Dr. Grover, and incoming president, Dr. Mohan Rajan, and all the eminent speakers who have joined us today. They will be presenting today. Their this webinar includes from pole to pole, like from the cornea to the orbit and to the retina. So everything is included into this webinar from pole to pole, and the speakers are very good, and all the panelists, they are expert in their field. I welcome you all to MP, and my really a great pleasure. Dr. Shweta has done a wonderful job in forming this the webinar and outlining it. All the discussants present over here, I really appreciate their participation and I welcome them. And Clarinet, I really appreciate your participation to our MP State and ocular trauma webinar. Thank you. Without much ado, let us begin this. Please, Dr. Shweta.
Thank you, Dr. Bhasin, sir, for your opening remarks. And let's move to the scientific deliberations. I would like to call upon young proliferant surgeon Dr. Nikunj Tank from Indore to speak upon traumatic cataract case-based surgical decision-making. And discussants for this topic are Dr. Rajiv Chaudhary, Dr. Pawan Sthapak, sir, Dr. O.P. Agarwal, and Dr. Vinita Ramnani. So your time is 8 minutes, Dr. Nikunj. Please stick to your time so that we can have sufficient time for discussion. Please start, Dr. Nikunj.
Thank you, Dr. Shweta ma'am, and thank you, MP State Ophthalmology Society and Ocular Trauma Society for inviting me here for this wonderful webinar. I'll just start sharing my screen. Yeah, is my screen visible and my voice is audible to everybody?
Perfect. Yes, please.
Yeah. So hello and good evening, everybody, and it's an honor and pleasure to be here among the stalwarts of ophthalmology of India. And I'm humbled and honored to be here being a young ophthalmologist. So my topic is to discuss about traumatic cataract case-based surgical decision making. I don't have any financial disclosures. So as a cataract surgeon, this is what we want. We want a good dilated pupil. We want grade 2 cataract. We want patient to choose a premium toric or a trifocal lens, and it pays us a good amount of money. The job is done in less time, and the outcome is also fabulous. But that is not the case always. We come across all these cases which will require more time, which will require more energy. The patient, even if you give your best, sometimes the outcome can be suboptimal, and but you still have to deal with all these cases. So what extra is required? So apart from our routine instruments, what we have in the OT, we need to have extra devices like capsular tension ring or pupil expansion device, iris hooks, all these Prolin sutures, microtrine forceps and scissors. When you are handling a traumatic cataract cases, because you will never know what you will find in when you on the operating table, and always have ventrectomy on standby or always ready because you will most of the cases it is required depending on the trauma. So I'll be sharing 3 cases. This is the first case which I operated when I was in Sitapur actually. So it was a 22-year-old male who had a trauma by a large rubber band. So fortunately, still it was a closed globe injury. There was no perforation, but you can see there is more than 180-degree iridodylisis. When he presented, there was a dispersed heme in the anterior chamber. The IOP was 35, and his vision was only hand movement and with PR accurate and PL present. And his posterior segment was surprisingly, unfortunately, was normal. So this is how the picture looked. This is the other eye of the picture. Compared to that, you can see the complete, there is a significant fall of iris tissue in the anterior chamber with a blood clot there. So in such cases, first thing is to control the inflammation and control the IOP. So give topical steroids and along with IOP, along with AGMs. So after controlling inflammation, you can see there was a rosette shape of posterior subcapsular cataract which is visible in the third image, and the view in the anterior chamber is quite clear as compared to what was in the presentation. This is the surgical video of how I manage this case. So the iris tissue is completely in the way. So first thing is to manage the cataract. So after injecting OVD, first thing is to get this iris away from our surgical field. And no kind of pupil expansion device will help except for this iris hook. So iris hook is the only device which will help in such cases. So using iris hooks is quite easy. You just need tying instruments, and then carefully and gently you need to get the iris away from the surgical field, as you can see in this video. I used 3 iris hooks to get this iris tissue away from the central surgical field. The cataract was soft. It was very routine and easy surgery, so I'm not going to delay time for that. So after that, the iris hook has to be removed once you are dealing with the iridodylisis. So the iridodylisis repair, you need. I'm using a 90 Prolene suture, and I'm going to pass the suture through the 2 away from the sclera, where I'm making a scleral groove, which will help to bury the knots in that area. And for that, the conjunctival peritomy is done, and after the surgery, the peritomy is also closed. So using a double arm 90 Prolene suture, which with a straight needle, I'm using my left hand to pass the needle. This is the left eye of the patient. I'm sitting temporally, and my right hand to stretch that pupil, stretch the iris margin, so that it gives me an area of tissue bite, where I'm going to pass my needle. So you can see it is a bi-manual maneuver, but I'm a right-handed person, right? So just like most of us. So passing this needle through the sclera is difficult. So I'm changing my hand here. So now after passing the needle through the iris tissue near the root of iris, I'm using my right hand to pass the needle from the scleral groove, as you can see, and giving a counter traction with my left hand using a lens passer. So this is the one end of the needle which is passed. Similar way, the second end also will be passed, and you get a loop. So this is the second needle which is being passed. So in the interest of time, I'll be showing this is the second suture which was passed 2 millimeter away, around at 12 o'clock in the similar position. So interesting, what I want to highlight is the third suture. So this was a case of more than 180-degree iridodylisis. So for the supratemporal part, I have to switch my position because it was very difficult for the left eye to get that excess of the supratemporal part. So I switched. I sat on the superior end, and I'm using a different technique here, so the railroad technique. So I'm passing the needle from the sclera first, passing it through the iris tissue, and then using my other hand to get that 90 Prolene in the lumen of this 26 gauge needle, and they both will be brought out using railroad technique. Right? So this we do in fourth of pupilloplasty. So now I have 3 loops, and which are tied in the scleral groove. So in such trauma cases, sometimes you need to repair such kind of bad iridodylisis along with cataract surgery, which will require different, like 90 Prolene and different kind of sutures. You can see the pupil has regained its shape at the end. This is the another case of the pediatric trauma. Somehow I get a lot of pediatric trauma. It is surprisingly sad also, and most of these cases generally come from the periphery. So the 5-year-old boy, he came actually with a corneal tear with a corneal tear to me. He presented after 5 days of the initial trauma. This picture is actually post corneal tear repair and post suturing. So this is how it was at the presentation. There was a significant amount of uveal tissue prolapse, and it was actually 5-day old, so there was a kind of necrosis. So during the primary repair, I had to cut that tissue. This is fast forward 2 months, more than 2 months actually. I think 2.5 months after the primary repair plus the suture removal and everything. So because of these sutures, you can see there is a little bit of scarring and it will leave some astigmatism, which I'll be showing in this case. And the pupil is completely irregular oval. There's a loss of iris tissue in the nasal area. This is, I think, the right. So the plan was to do a cataract surgery. He also had a rosette cataract in that eye and do a pupilloplasty to reshape that pupil. So there was a significant astigmatism, so I decided to do a toric monofocal IOL. But and for the child, we do under correction of the power, which was also achieved. So coming to the surgical part, the capsular rhexis is a bit different as compared to adult cataracts. These tissues are more elastic. So my preferred method for pediatric cases is always using the rhexis forceps. I generally prefer Dr. Haldipurkar's forceps, which I really love. So using that forceps and using the grasp and regrasp technique, I was able to achieve an approximate size of 5 to 5.5 mm for the anterior capsular axis. The cataract was soft, only aspiration was done, no phaco powers required. But after removal of the cataract, you can see there is a white plaque there. So first I try to remove that plaque, switch the illumination to para-axial, and it was giving me better visibility. I tried to lift it or aspirate it from all around, but I was not able to do that. So in such cases, what you can do is, I'm going to show in this case that using 26 gauge needle, yeah, the generous amount of OVD is required. So I'm using a 26 gauge needle, the cystotome. I'm trying to lift that plaque away from the posterior capsule very carefully and very gently. And I was able to get the plane dissection plane in that area. I again switch back to coaxial illumination here to get that view for the retina. So after that, again, the same forceps is used to remove this plaque. It was coming as in toto, surprisingly. Sometimes it breaks, then you have to again grasp at that area and then remove it. Always inject OVD, just like we do in capsular axis. But in such cases, when you try to do this, you sometimes end up rupturing the PC, which I did in this case. You can see there is an oval opening in the posterior capsule. So important thing is to not this capsular rupture of an oval shape, let it be. I converted into a posterior capsular axis, which will be a circular capsular axis, which will have a strong margins, because this oval can go to the equator and we can have a PC split. So which will make the case even more difficult. So I was able to achieve 4 mm of posterior capsular axis by converting that oval defect of the posterior capsule. So now we have two capsular axis, 5 to 5.5 millimeter anterior capsular axis, and approximately 4 millimeter of posterior capsular axis. The IOL implantation was just like usual. You need to be careful that the IOL should also go gently. The toric IOL. I'll just fast forward that part. After that, the important thing is to manage this pupil. So I'm aligning the toric and then I'm injecting pilocarpine to bring down the pupil to the original shape, which was in undilated state. So I'm making a nasal paracentesis. Here I'm going to do two pupilloplasty sutures. So I'm using a straight 90 Prolene again. So I'm using my left hand to get the needle inside and using my right hand to stretch the pupillary border with a micro tying forceps and get that grasp of the tissue and then get a tissue bite into the suture. Then there is the first bite of the pupilloplasty suture. Now getting the second bite on the opposite side of the pupillary border. Using my left hand to stretch the pupil and right hand to pass the needle. So switching of hands actually helps. And I'm bringing the needle from the main port out. And we have to create the loop. So the area between the first entry point and the first bite of the iris tissue is brought out. So you can do single pass fourth row pupilloplasty also, which is popularized by Dr. Amar Agarwal sir. But it was a pediatric case, so I wanted to do multiple knots. So I've done a Sipser sliding knot, which is so fourth row pupilloplasty is also modified Sipser sliding knot. So I did 3 passes first, tied that knot. I will bring that loop again, same, and I will do 2 more passes. So it will give a secure knot for the patient. So similar way I did. So this is the now 2 passes of the inside the loop, and then the knot is tied. And the suture ends are cut using micro suture. Similar way, I did the second suture. And just to save time, in the interest of time, I'm just forwarding because it's the same way. And this is how it looked after the procedure, and you can see the pupil has lifted up. It is more centered over the cornea, and patient has achieved good anatomical as well as surgical outcome. Coming to this third case, so this was a case which came after 4 years of the initial trauma. You can see there is a calcified, partially absorbed cataract with a mid-dilated 4 to 5 pupil. There's a 360-degree sphincter damage. On dilated examination, you can see there was a significant calcification of the capsule as sorry. Yeah. So the plan was to, if I can spare the capsule and have a support, then I would want to do a three-piece IOL with optic capture. That was the primary plan. And sometimes you will end up with complete zonular weakness and surprising events. So lensectomy and vitrectomy was always a backup plan. So I went ahead with the first plan, which was capsule sparing lensectomy with three-piece IOL, and I wanted to do a circle arch pupilloplasty in this case. So what is capsule sparing lensectomy? So in normal lensectomy, we try to eat the lens with the anterior capsule, posterior capsule, and then either you do a SFIOL or iris flow or something like that. So in here, we are going to use vitrectomy cutter and try to preserve the capsule and then do the rest of the LF procedure. So anterior capsular access was near to impossible. It was very calcified anterior capsule. So I could get some flap in the periphery, which I elevated and then made some irregular oval-shaped rexes in that peripheral area, so which gave me access to the inside of the capsular bag. Once I got that, I used the anterior vitrectomy cutter to remove rest of the things, and you can see the calcified anterior capsule was difficult to cut even with the anterior vitrectomy cutter. Somehow I was able to achieve that and remove the cataractous lens. At this point of time, the posterior capsule is intact, but the anterior capsule is so ragged that if I put a lens, the lens will not have a proper support. So I decided to do a primary posterior capsular access because there was also a posterior capsular plaque in this case. So I used micro scissor to get the initial flap. You can see here. So this is the flap in the posterior capsule. Using the I'm using the capsular access forceps, the Habipurkal forceps, and then we're trying to get that posterior capsular rexis done. Always the principle again remains the same. You need to keep injecting OVD to keep the flap flat and keep the vitreous back. There was some vitreous fluorescence which was handled with the anterior vitrectomy at the end. So the capsular access in that area was completed because there was a little bit of calcification and I was not able to get the pool of that area. So I was able to achieve fairly circular posterior capsular access in this case. So I implanted a three-piece IOL and captured it behind that posterior capsule. So it will give a better stability to the IOL. So the haptics are in the sulcus and the optic is behind the posterior capsule. So now is the time to do a circle arch pupilloplasty. It is quite difficult a bit because you need to pass that suture 360-degree along the pupillary border. So I'm using my right hand to hold the needle and using my left hand to pass the iris tissue in one quadrant. So now the one quadrant is done between nasal iris and the inferior part. Now again the second temporal quadrant is done the similar fashion. The second arm of the needle is passed from the nasal paracentesis again, and the supranasal quadrant is done. It is you have to do a purse string suture along the pupillary border. The superior part was a bit difficult because I was holding the needle with my left hand. It was very difficult. Then you don't need to complete 180 degree. You complete 45 degree and then again come out like that. So now I have passed the needle all around the pupillary border. I'm going to tie that knot. So first knot was Macallan suture. I tried to tie the knot outside and then the knot was slid inside, but it was getting a bit difficult. Then I decided to create a loop, just like we do in orthopupilloplasty. So I'm going to show that. So the loop between the second knot is created just by creating the loop of the one end of the suture, and the free end of the suture is passed again three times from this loop, and then both ends are pulled inside, and you will get a complete knot. So this is how it looked at the end. You can see a circular, well-centered pupil at the end, and post-operatively also patient did very well. So this is a recent case. In the interest of time, I'm not showing the video. This is the pictorial representation. It is a traumatic subluxated mature cataract with a iridodialysis and pupillary sphincter damage. So the lens was removed. Actually, it required SFIOL. So then after that, the iridodialysis repair was done, and at the end, pupilloplasty was done. And you can see in the last picture the surgical outcome of this case. So this is how it looked at the end. So traumatic cataracts are like, the Asura of known as Hiranyakashipu, and you need to become like Lord Narasimha and be innovative and creative to handle such cases because every case will be different. Thank you so much.
Thank you, Dr. Nikunj, for very insightful and clinically rich presentation. To take the discussion forward, may I request our discussants, Dr. Pawan Sthapak sir and Dr. Vinita Ramnani, for their inputs. And Dr. Pawan Sthapak sir, I would like to know how much delay for cataract surgery do you go for immediate, or you wait for some time and then plan the cataract surgery in post-trauma cases in which the corneal repair has been done?
Usually, we first repair the cornea and wait at least for uh, 1.5 months. Then we do the cataract in our setup.
Thank you, sir. I think that is a better approach because the cornea also
Mm.
stabilizes, and if it is there is no capsular rupture, and we think that there is not vision is not an issue, then we can definitely wait for some time, wait for cornea to stabilize, and then plan for it. But if there is a mature cataract to avoid amblyopia in young patient, I think we can go for immediate cataract extraction.
If there are,
If there is,
can I
It
say
depends on
something?
yes, sir.
the patient when it comes to us. If it comes late with the old corneal tear and white cataract, then we do both the things simultaneously.
Yes, sir. Yes, sir. Very correct. Purensa, you wanted to say something?
Yeah, I think it is very clear, very nicely presented, Dr. Nikunj. I really appreciate the way you have managed all three cases and the fourth case slide you have shown. And a
Thank you.
beautiful presentation, Dr. Nikunj. And I appreciate your acumen. And Dr. Pawan has also replied very nicely about that we should wait for 1.5 months. So the dictum says that we should wait for 4 to 6 weeks after the primary corneal tear repair. And we can do early when there is a rupture of the anterior capsule, loose cortex, or the lens is swollen. Then we can plan early if the IOP is under control and if the uveitis is under control and the corneal surface is regularized. So these are the things. And in case when there is any intraocular foreign body, or there is a posterior segment pathology like retinal detachment or non-absorbing vitreous hemorrhage or anything which is or there is a endophthalmitis, then we should go for early cataract surgery. So this is the way we should proceed, looking to the condition of the patient and the type of the trauma, whether it is open globe injury or a closed globe injury. So
Very correct.
subluxated cataract and dislocated cataracts. So it all depends on the type of cataract and the type of injury and the associated findings.
Dr. Vinita, would you like to add something to it? You can unmute yourself.
Good
Yes.
evening, everyone. Nikunj, very well presented cases, and I think the traumatic cataracts are one which requires a lot of efforts in planning and execution. And not only this, it requires a lot of follow-ups also. I have seen very good placed IOL, very good handling of the iris, cornea, everything. But the glaucoma is one which is being not taken care of. So I think we had a good glaucoma webinar before that all cataracts which you are operating, Dr. Nikunj, or whosoever is operating, we have to take care of glaucoma because the incidence of glaucoma is quite high in this patient, and especially in our scenario, the trauma is more common in younger people and children. They require more careful evaluation for the glaucoma and IOP management.
Very correct, Dr.
Only one
On
Vinita.
this
question
note,
I
ma'am,
have for
I do
Dr.
my
Nikunj.
sorry,
I
sir.
have one question for Dr. Nikunj.
Yes, sir, please.
Okay. Uh, Basically, that is very excellent presentation in all the cases, three cases. I would like to ask, you use 90 proline or 10-0? In these cases, you have used
S-
90 proline.
sir, for iridodialysis, I have used 90 proline. I think for the pupilloplasty, I use always 10-0 proline. 10-0 proline for the pupilloplasty.
Okay.
Thank you. Thank you. We have Dr. Prashant Bavankule sir with us. So how often do you go for a circle arch, keeping in mind the posterior segment trauma? Do you go for pupilloplasty? Because the pupil won't dilate later on. How do you manage?
No, the
such
thing,
patients?
see, predominantly the traumas which Dr. Nikun just shared is anti-segment. So most important thing is you have to rule out comorbidity whenever you are trying to reduce the size of pupil, either to create an iris pupillary diaphragm or to avert an astigmatism created by cause of secondary corneal scar. So once you rule it out, then I think you don't need to really worry about it. Second most important thing is Mehul sir, you need to mute it up. Please mute it. Yeah. Okay. Second thing is you also can manage an good indirect ophthalmoscopy through 2 or 3 millimeter. And nowadays with wide field fundus cameras, well, you can have almost 160 degrees or 200 degrees of view with even in a small pupil. So these are the advantages with newer technology, as well as if you are very adept in this indirect ophthalmoscopy, you can see through the small pupils. But most importantly is rule out a posterior segment trauma or a comorbidity, then only think about creating such small pupils.
Can I add something?
Yes, sir, please.
Sweta, let me thank MPSOS, also OTSI for the wonderful opportunity. Purendra also, thanks a lot. What wonderful cases I think Nikunj has shown. All the three cases were gems. And in my opinion, it is so good. Only thing is, when you have a large iridodialysis like that, and nowadays you do what is called the trocar assisted iridodialysis repair. It makes your life easy because once you put a trocar there, the trocar which you use for the vitrectomy and all that, so the same trocar you can put it in the anterior chamber, and through that trocar you can pass the needle, long needle. Otherwise, the long needle goes in, you do not know where it goes, and sometimes you
Correct.
don't have any control. But if you go through the trocar, and especially when the iris is a little thin there on that side, and large iridodialysis, it works very easy. You can just turn the direction of the trocar wherever you want to, and then
Right.
makes your life very easy in hydrolysis repair. I also use 90 proline for hydrolysis repair and 10O proline for the pupilloplasty. Encerclage is good. It's a little difficult technique. It takes a little more time, and it's much better. The cosmetic results are much better than an SFT. Because SFT, if you try to make the pupil small, a lot of gaps will be there in between. But in insect class, you will not get that. It's like a purse string. All that. It's a very good technique. And the pupil dilatation is good enough as Prashant was saying. And we'll be able to manage the posterior segment fairly well as well. So I think beautifully covered. Nikunj, really congratulations to you.
Thank you,
Yes.
sir. Thank you, sir.
Thank you, sir, so
Yeah.
much, sir, for your inputs. We also have
Wonderfully done. Only one thing I would like to add. You can use the AC maintainer rather than trocar for
Uh,
pupilloplasty.
Sir, AC maintainer is to maintain the chamber, no, sir. Trocar, what we do is we put
for
a
the rail,
through the trocar, we pass the needle, sir.
for railroading it, railroading it.
Railroading the so you through the trocar, you pass the needle, and
Right,
then
right.
because you have better control with the trocar on
Mhm.
the iris tissue. Otherwise, you're passing the long needle, the needle will go this side, that side. You can create a problem in the desmids and all these problems. Yeah.
We also have Dr. Gautam Parmar. Dr. Gautam, he has an excellent technique of doing iodialysis repair, large iodialysis repair. Dr. Gautam, would you like to add something?
Yeah, ma'am. That is my preferred technique. I hope I've shown lots of time. So in that case, I use. Am I audible, ma'am?
Yes, sir,
Yes,
you are.
yes.
Yes, you are
Yeah,
audible.
yeah, yeah. So I use a hollow 30 gauge needle to pass the sutures. I first thread the needle through the hypodermic 30 gauge needle, and then I pass that needle through the side port, just opposite to that iridodialysis, and then I just what we have seen in the sewing machine technique or cobbler's technique. So I just show that technique, but I did some modifications, like I didn't made any I mean scleral groove there, because the purpose of scleral glue is just to bury the suture. So I have a different technique of burial of the sutures. So that's why I don't use the scleral groove.
Thank you, Dr. Gautam. Let's move on to our next talk, that is by Dr. Kamal Preet Likhari. She'll be speaking on management of orbital foreign bodies, guidelines and pointers. And discussants for Dr. Kamal Preet talk are Dr. Chandravanshi, Dr. Bhagesh Pore, Dr. Prabha Gupta, Dr. Animesh Sahu, and Dr. Deepak Soni. Dr. Kamalpreet, please share your screen.
Is the screen visible?
Not yet, Dr. Kamalpreet.
Just 1 second. Is it visible now?
Yes, it is visible. You can make it slideshow.
Yeah, 1 second. So am I audible?
Yes, you're audible too.
Okay. Right. So, good evening, everybody, and thank you, OTSI, for this opportunity. I'm going to talk about guidelines and pointers in the management of intraorbital foreign bodies, which we know are extraneous objects which are partially or completely within the orbit, with or without penetration of the globe. They can be organic or inorganic and can be purely within the orbit or can occupy the adjacent spaces. They're always caused by high velocity projectiles, and in cases of falls and all, like a fall from a height, it is the body, the human body, which acts as the projectile, and the actual object, which is the foreign body, remains stationary. In our setup, in addition to other usual causes, we have sports like gilli danda and festivals like Jallikattu and cracker injuries in this thing, Diwali season. Mostly it is young working age males who are affected and can be very varied. And patient may not even come with a history of trauma. We need a very high index of suspicion. Case in point, this little girl who was brought in with a very vague history, and we felt that the cellulitis like edema was totally out of proportion to the small oozing wound at the medial edge of the brow. And CT revealed a small metallic foreign body. This was lodged at the junction of the lateral orbital wall and the temporal bone. So this turned out to be an air gun pellet, and we decided to leave it behind. We just controlled the inflammation. So management starts with a very thorough history, and examination is not complete without a proper palpation of the adnexa. And then we move on to investigations. Now, if we have a radio opaque object, or if we are just screening for a foreign body, we need to do a CT. We only do an MRI if we are sure that it's not a metallic foreign body. And if we are suspecting some soft tissue injury, or we are very suspicious of a foreign body but it is not visible on CT. X-ray does not really have a role in management of foreign bodies, so hands down the first investigation of choice is a CT scan. Right now, there are certain foreign bodies which should always be removed. These are organic ones, infected ones, those made of toxic materials, and even large objects, because by their sheer volume, they are going to cause a certain amount of distortion in the orbit. Also, sharp and jagged objects which may move with the ocular muscles and the movement of the eye. Additionally, all foreign bodies which are anteriorly located and can be easily removed should be removed, even if they are made up of non-toxic materials. Now, which ones can we leave behind? Those which are small and smooth and inert. So usually it is pellets, but also we should think of the graphite tip of pencils and small glass beads. But when we are leaving any metal piece behind, we need to take a thorough history for nickel allergy. And also remember that even if the metals are inert, they can lead to complications later and may preclude the patient from undergoing an MRI in the future. If we do decide to remove it, we can either follow the path of the foreign body or take an alternative path depending on whether it is palpable or its impression is visible on the surface, and also whether it is made up of a brittle or a friable object. But always remember to make a generous incision, because the wound of entry generally collapses and becomes small. Now, here are a few illustrative cases. Wood is very common, and it is made of layers of fibers with a porous structure. Fresh wood is well seen on CT, and dry wood on MRI. Ultrasound picks up both types of wood, provided they are not against a hard background like bone. Right, so but the usual presentation is a mist foreign body, where you will have these air pockets caused by the bacterial infections, which are always present with wooden foreign bodies. As seen in this lady, she has this typical discharging sinus, which is also a characteristic presentation. And you can see these pockets of air. You can't actually see the foreign bodies, right? Whereas in this case, because it was dry wood, you can see the wooden object very clearly. And there were these huge bamboo pieces. In this little child, we could not see any foreign body dissolving edema. Metal is well seen both on X-ray and on CT. And in this patient, we had to disinsert the medial rectus to remove this large piece. And in this one, we just followed the route of entry. This piece was very huge and actually very heavy, right? It was rusted and crumbling. Now, glass, the visibility depends on the composite material, but in general, it is well seen on CT and on X-ray. This lady had, so in this case, you can see that the impression of the foreign body is visible externally. So you can see it on the eyelid. It was just against the frontal bone here. And this was a looking glass. So this was particularly difficult to remove because it was against the frontal bone. And when we everted the eyelid, the pieces could have been crushed. And when we were removing it, it could have caused a corneal or a scleral tear. Happily, that did not happen. And there are many considerations with firearms injuries, which again are very common in our country, actually all over the world these days. So we never know what the material actually is. They generally cause fracture of the bones and may be stuck inside. And if they are big, we might not have the suitable instrument for them. There is some associated gunpowder, so cautery use might be difficult. And another thing is that sometimes they keep on moving, like these small pellets, like this, the bird shot. You can see they're subconjunctival and they were within the orbit. Also, there is one near the medial canthus. All of these were very difficult to remove because they kept on migrating deeper. Right. This was a big bullet. So this was impacted in the apex of the orbit. It had fractured the apex and it's lying against the middle cranial fossa. A lot of bleeding. I did not use cautery because there was gunpowder scattered all over the surface of the eye. And when I did find it, it was initially very difficult to find. And when it was found, it was difficult to remove because it kept on slipping behind. So every attempt to grab it resulted in a bit of a posterior thrust. So this is when we finally got it out. So this was the bits of gunpowder, and this is the patient later. Now, visibility of stone again depends on its composition, though CT is the best modality. Usually, it is part of an assault. Someone has hurled a stone, but also very common, it is a part of a cracker. So, in this child, this piece of brick was part of a cracker which damaged his eye. And crackers also have other complications. Now, this little boy had this infected tear, and CT just showed kind of a diffuse infection, fibrous tissue, no foreign body as such. But after treating the infection in the OPD itself, I kind of felt that there was something inside. And you can see here, luckily, this boy cooperated because the surrounding tissues were already so dead. This was pretty deep inside. And we got this large wad of paper right along the medial orbital wall. Now, a foreign body need not always be an extraneous object. In this patient, it was a piece of the frontal bone which was impinging on the superior rectus. So I needed to do a floor fracture repair. So if I lifted the globe up with the fracture repair, it would have damaged the superior rectus. So I had to get this out first. So I did a superior orbitotomy, and it's actually shaped like a shark's tooth. This girl fell down when she was carrying a pencil. That is the history we got. And you can see a hyperdense shadow with a distorted image of the globe. It's not very clear whether this shadow is inside the vitreous or outside. And it doesn't look like a graphite tip. And they did not tell us that this was not a graphite pencil, it was a color pencil. Now, we all know that graphite tips can stay even inside the ocular tissues for several years. There's a report of one a patient having it for 37 years. But this is a color pencil which contains animal wax and pigments and kaolin clay. So this is very, very toxic and needs to be removed. So happily, our patient did not have much inflammation after complete removal of this. Now, what are the learning points? We can either decide to leave a foreign body or remove it, depending on the composite material, on its size. Large ones need to be removed, shape, jagged ones should be out, and its location. Investigation of choice is a CT. Every case needs an individualized approach. The route can be either the wound of entry or a separate incision. But we need to remember that the incision should be larger than the wound of entry because that usually collapses. Now, one more thing which I would like to emphasize here, we should never attempt to remove a foreign body without proper investigations. And we should have respect for the ocular tissues in that we should not think that we can just yank it out. For instance, in this patient, it looks very superficial. So you feel very tempted to, just grab hold of it and pull it out. But when you do a CT, you find that it is pressing against the globe. And when you remove it, you realize that it has thorns. So you could actually have really destroyed the eye if you had pulled it out. So to conclude, I'd like to say that orbital foreign bodies are always a challenge, whether we decide to remove them or leave them behind. They inflict considerable damage, and the surgeon should ensure that the removal does not cause more harm. Thank you.
Thank you, Dr. Kamalpreet, for such wonderful presentation and cases. I think you have brought out both the practical challenges and the real world solutions very nicely. I must congratulate you, Dr. Kamalpreet. May I request you to
Thank
stop
you.
sharing your screen and the discussants, Dr. Deepak Soni and Dr. Prabha Gupta. Dr. Deepak and Dr. Prabha, would you like to discuss something?
Yes, ma'am. It's always been a pleasure to listen to you, your presentations, ma'am, Dr. Kamalpreet, ma'am. Ma'am, I would just like to ask, in cases of wooden foreign bodies, there is always remains a dilemma, like in early cases when it sometimes it mimics with the air bubble. Looks like give an impression of a very hyperdense air bubble. So, ma'am, how to approach in such cases? Second thing, ma'am, the last learning part you said, the removal of a wooden foreign body. So once we see like the object size of the wooden foreign body is like 3 mm, 4 mm, or more than 1 centimeter, how deeper we need to go while performing the orbitotomies, because there is always remains a risk of rupturing the important structures. How do you approach such cases, ma'am?
So, to answer your second question first, if you saw that gentleman I showed in the end, so that was not only for wooden foreign body, that was for any foreign body. So normally when, especially that gentleman was uncontrolled diabetes, hypertension, cardiac, he had multiple systemic risks. And at a point, even you are tempted to, not make the patient undergo such a lot of anesthetic problems. But what I did there was that initially I did a Lynch incision and enlarged the wound of entry. And once you have, see, like if you've done fracture repairs, you need to be able to visualize the fracture from all sides and then place the implant. Similarly, when you're removing a foreign body, you want to be able to visualize all the tissues, make it move first, make sure that it is moving and none of the tissues is snagged inside, and then you get it out. So in that, if you follow this protocol, you will not be causing any additional harm.
Yes.
Yeah,
Ma'am, is
just
there any
Sorry,
role
what
of...
was your first
Yeah,
question you had?
yeah. No, ma'am, please continue, ma'am. Yeah.
Yeah, so that is what you do. So if it is 3 mm, 4 mm, if we are removing a tumor and if it is extending to the apex, we will go up to the apex. So if you are removing a foreign body which will already have caused damage, it is more important to dissect all around it. Go even behind it. You can use ribbon retractors. Go
Yeah.
behind it. Make sure it is mobile and then to get it out.
Yes, right.
Just I want to add one. Am I audible?
Yes, sir.
Yes.
Yes,
Yes.
yes.
Yeah. So any kind of
Hi,
foreign
Jayanta.
body is not a issue. Yeah, not a issue. Size is not a matter. Location is not a matter. We are well equipped for all. So point is that as Kamalpreet already mentioned. So proper dissection is important, and proper localization before we start,
Yes.
before we plan, proper identification. If you have any doubt, is it a foreign body, metallic or non-metallic? So preferably initially we can go for a CT scan. It's very safer. It may be metallic. Metallic is contraindicated. So in some cases in road traffic accident, it's very difficult to differentiate is a metallic or non-metallic ones. For juniors, I am telling, so first you can proper history taking, you can evaluate, and we assessment, proper clinical assessment, ABC for all the patient, all the parameters, then the CT scan preferably. Then if we suspect glass on CT and wooden, preferably in the same, we can go for a MRI. With all other hospitals radiological investigation, that lab, there is a all machines are side by side. Suppose in one room there is a MRI, another room in CT scan, so we can transfer immediately. This is it, because it's not a so much of cost effective in case of a, if we consider the injury and polytrauma cases.
Very
In
correct.
polytrauma, protocol is that we can go for a one the generalized scanning for the whole body scan, then we can think, and that radiologist or on the basis of our that what, and before starting the surgery we should be sure type of the foreign body, location, relation with the blood vessels, and accordingly you can prepare for any kind of, it may be intraocular, it may be a intraorbital. I
Uh,
remove lots of up to the
I
intracranial
would
also.
just like to interrupt here, Jayanta. So
Yeah,
it's not always possible to be 100% sure about the composition. Even history is not always very forthcoming.
yeah,
So
yeah,
you
yeah, right.
always need to be sure where you are going. And secondly, what tissues you'll be dealing with, the
Yeah,
anatomical part you will be dealing with.
yeah,
And
yeah,
once you have decided, if it is an unknown thing, it is better to get it out because you don't want to regret later and tell the patient that this is what I advised. I'm sorry, I
yeah,
wasn't sure.
yes,
So
fine, fine.
100% surety is never
Yeah.
That's why
possible.
suspicious mind and that location
Yes.
at least extend somehow. We should be fully well equipped and fully prepared
Very,
for all kind of that problem.
very true, Dr.
Yes.
May I add
Jayanta.
something,
Sure,
Dr.
sir.
Shweta?
Yes,
Thanks.
yes, I was about to
Yeah.
have your opinion. Yes, sir, please.
I think I'll just sum up some of the things which Kamalpreet said so
Amazing.
beautifully. One is that you have to individualize the management. There is so much variability that you get things like grease inside the orbit, or you may get a fish hook inside the orbit, or you may get a foreign body which is small but hidden, manifesting only as um, a small fistula, or sometimes as a periosteal infection or a osteomyelitis. So there is such a huge lot of variation that you should not miss out on the possibility of there being a foreign body. And that is where, as she emphasized, after a metallic foreign body is ruled out, then all suspicious cases get an MR done with a specific instruction to the radiologist to look for one. Otherwise, they can get missed unless there is a special attention given to the secondary effects of the foreign bodies, such as the wooden foreign body, and if a special effort is not made to look for the foreign body itself by cuts which are quite close, 1 millimeter cuts at times, to not miss the small foreign body. So I think not missing out is one, making sure that you minimize the damage during your procedure, plan it well, see the location well, see the structures around, and then carry out the procedure. So, number one, carry home message: make sure that you're not going to cause more damage than the benefit that you're going to do. Don't miss out on foreign bodies. And once you have decided that you want to do it, know what structures you will be around so that you don't cause a damage. I think these are some of the very basic things that Dr. Kamalpreet emphasized so well.
Thank you so much, sir. Thank you so much.
I can
Do we
add
have Natarajan, sir? Yes,
Shweta.
yes, sir. Yes, sir, Mohan, sir, please.
No, I think we had to compliment Dr. Kamalpreet for the wonderful presentation. I just wanted to ask Grover sir, as Kamal, and all other expert panelists here. Sorry, I got a very bad throat.
Get
Whether
well
we
soon.
any role for endoscopic surgery, sir?
See, in the orbit, the endoscopic surgeries have a role basically only for those which are located near the medial wall. For all other cases, the visualization with endoscopes is grossly impaired by the orbital fat present and all other structures present. So you don't really benefit so much. Navigation can be helpful in difficult cases, cases near the apex, or cases where you feel that you will have a difficulty in reaching out. There's a deeper, smaller foreign body. Those cases, navigation can be helpful. But endoscopy in orbit is only for those lesions which are nasal endoscopic approaches near the medial orbital wall. There it is a help.
Okay, thank you.
Thank you so much, sir, for your inputs. Let's move on to the next talk by Dr. Gautam Parmar. He'll be speaking on hidden damage in ocular chemical injury. And the discussants are Dr. Ankit Deokar and Dr. Bharti Ahuja.
So, am I audible, ma'am?
Yes, sir, you are audible. Please
Yeah,
start.
yeah, yeah. So, good evening, everyone, and I would like to thanks Dr. Shweta for giving me this opportunity. So, I will be speaking on the hidden damages in the ocular surface chemical injuries. So we know about this phenomena in our community medicine studies, that something which is obvious is much less than what is hidden inside the community. So similarly, in the chemical injury, I must say that the iceberg phenomena is applicable. That what we have seen on first impression is something very less, which is which is hidden inside. So as you can see here, on the left side, you can see the obvious pictures which is revealed on the day one, that a lot of injuries to lids and are there. But actual what is hidden inside that is, there may be a granuloma, maybe a limbal ischemia, which result into the formation of the even may lead to the phthisis. There are a lot of lid trauma which may lead to the ankyloblepharon formation, conjunctival trauma which causes symblephrons, entropions which may eventually lead to the perforations also, and I may went up into the phthisis. So all these things remains hidden on the first instance. So if you compare the acid versus alkali injury, the mechanism that the acid causes coagulation of the surface proteins, and it probably create a protective barrier, so let less penetration of the further acids inside the eye, and that causes less damage because of the less penetration. While in the alkali, it causes liquefaction of the tissue, and so that's why the alkali goes deep and deep and causes more damage. And if, as I said, that alkali causes more damage, and what we have seen in our day-to-day practice, there are most of the chemical injury cases come to us with, because of the means, more than 90% of them are because of the alkali, and most of them, about 99% of them, are because of either tuna packets by the in the kids, and in adults it is mostly because of the carbide gun injuries. And even in the women, we can see to a less amount due to whitewash or household chemicals. So what mechanisms we have seen in our day-to-day life, that mostly the children squeezes that pouch from the near their head, so it goes just inside the eye, and mostly it remains trapped inside the superior fornix. So that causes, and that may be not washed while routine irrigation, and it may remain there, and they cause more deep and deep damage. So lot of structures can be damaged later on, which remains hidden on the first instance, like as I said, lid traumas, conjunctival traumas, or even the limbus injuries because of the limbal ischemia, or corneal trauma because of the impacted line inside the cornea, or even the deeper structures like ciliary body, iris, and even the lens. So this can be, it happens. So we consider them one by one. Like you can see here in the left side picture, you can see the whole lid margins are charred during a carbide gun injury. So this result into the formation of the your ankyloblepharon, and your whole lid is stuck to the your globe, and even it results in the entropion, cicatricial entropion, which eventually rubs the eyelashes rubs your surface and may result into the persistent defect and further melting and even perforations. So all what we need is uh, uh, we may need assistance of the ocular surface, oculoplasty surgeons to reconstruct the lids and entropion corrections, or we may need mucous membrane graftings and all. Second thing, the lot of damage to the conjunctiva and fornices can happens, which remains hidden. So as you can see here, lot of symbolifrons were formed, and they may further need to correct by the, repeated procedures may be needed, repeated amniotic membrane transplantation. What we can do to minimize all this trauma to the conjunctiva is that we should do meticulous lime particle removal and amniotic membrane transplantation. And one more thing additively we can do is the allo slat. So we can use a cadaveric young donor tissue within 24 hours of harvesting of the cornea. We can use the allogenic slats from that cadaveric tissues, and the advantage of doing alloslat here is to faster the epithelialization of the surface and less symblepharon formation. And and the most advantage is that there is no need of any immunosuppression, as we can require in the living related donors. Again, there is a sequelae like damage to the limbal stem cells are there, which results in to the formation of such type of pannus. So, we should assure before going for the definitive correction of such thing that we should your globe should be, means your eyes should be opened well, and then we can go for the slat, that is simple limbal epithelial transplantation from the other healthy eye. This is only applicable for the unilateral cases where we can take biopsies from the other healthy eyes, uh, and you can place that biopsies throughout the your corneal tissue after dissection of the pannus over the amniotic membrane transplantation. And you can see here the sequential images how it will not only restore the limbus anatomy, but it clears the cornea also simultaneously. This is again a second case of a complete total 360-degree limbal stem cell deficiency with central corneal haze also. And we performed slat here, and you can see the results after about a 6 month. Your cornea gets cleared and limbal anatomy get restored. Now, next come to the damage to the cornea. So lime impacted inside the cornea can damage it well and causes lot of opacities. As you can see here, superficial limes can be removed, but mostly, especially in the carbide gun injury, we have seen that lot of lime impacted inside the cornea, and it goes deeper and deeper and may consolidate to deeper layers. So we come across one such case, a 21-year-old male after post carbide gun injury presented to us with hand movement vision and this kind of picture where some symblepharon is there and the lime is impacted mostly deep into the corneal layers, while the superficial layers remains relatively clear. So we, instead of going for penetrating keratoplasty, we applied a different approach here. So first I made this tunnel just near to that near the limbus. I started doing this tunnel half thickness. You can see my crescent is visible well. That means the anterior cornea is clear a little bit. So I am dissecting the tunnel. The whole length was tunnel was dissected using this blunt lamellar dissection dissector, and then I entered the anterior chamber, filled viscoelastic, and then I bisected this posterior lamella into two halves, and then I removed both the halves separately. So I am first removing right side half. You can see the lime impacted inside this deep lamella. So after removal of this deep lamella, I prepared a endothelial DSEC graft here. I mounted cornea on the artificial antechamber, prepared the dissect graft. You can see marking, and then I cut it about 8 mm, and then I implanted this graft inside the globe and positioned it well, and after that I applied tamponade, and then I secured the tunnel using a continuous 10 nylon suture. So you can see this is first post of the picture where the vision was improved a little bit and the graft is well settled, as you can see on the anterior segment OCT. After 1 year, the vision becomes surprisingly 636 unaided. So, and you can see the clear visual axis, though there are still some residual line was there, but the vision is good and patient is very happy. So this approach can be tried if the very specific subsets of the patient where the Lyme impacted deeply into the cornea. This is another such type of case where after doing my slit, I performed the penetrating keratoplasty. The cataract was also there, so I did cataract surgery also in this case, and patient doing well. Then come to the damage to the glands of the, as I said before, that lot of trauma to the lids can happen, and which eventually leads to the damage to the glands of lids and conjunctiva, and which may eventually leads to the dry eye formation and may need long time tear substitutes. But mostly in the chemical injury cases, what we can do in bilateral cases, there is possibility of type 1 Boston keratoprosthesis available in India by the RO lab, RO Capro, which can be done, and we have done this case with bilateral chemical injury. This is 6 months post-op picture, and the vision is reasonably good in this patient. So this can also be tried. Then come to the further deep damage can causes either increase of the intraocular pressure because of the trabecular mesoscleral damage, or maybe pressure may be decreased because further injury to the ciliary body and due to limbal ischemia. So intraocular pressure, increase in intraocular pressure happens because of the damage to the trabecular meshwork. And what we can do, we can manage with the either beta blocker, but we should avoid prostaglandin analogs because they may induce inflammation and further damage to the trabecular meshwork. So basically it is a domain of glaucoma surgeon, but for the lower in the intraocular pressure, it's definitely a domain of the cornea surgeon, where the damage to ciliary body can happen due to ischemia. As you can see in this case, there are 360-degree ischemia with diffuse corneal edema and inferior limbal perforation was also there, and there are SE exudates are there, and the globe is in a gross hypotony position. So here I performed tenoplasty. The purpose is to increase the vascularity to the limbus and provides vascular pedicle to ischemic sclera and to salvage the globe. So here I am just showing the technique of doing tenoplasty. Here I am separating the tenons from the overlying from the globe and freshen out, removing all the necrosed tissue from the globe. Here is the perforation. So I washed that exudates and fill it with the viscoelastics. And then I separated tenons from the overlying conjunctiva and make them free. So I have this 360-degree rim of tenons which made free from the overlying conjunctiva and underlying globe. And then I secured these tenons near the limbus, and even I secured these tenons over the cornea also, because my purpose is to just salvage the globe. I need a whole penis covered the cornea. I don't want a clear cornea here. In this case, my purpose is very clear that I have to save the globe, because there is high chance of the eyes may go into the phthisis. So I covered it with the means I sutured the tenons all around, and then I placed this amniotic membrane graft over it, and then I secured with the glue the whole amniotic membrane, and then I further used some sutures also there to get a better security. And this is post-op images. You can see the sequential post-op images, and the globe could be salvaged. Epithelialization of the ocular surface with the very integrated amniotic membrane, and there are some symblepharon formation is there, but that is desirable. So, and you can see the B scan showing that the well preserved globe. So the take-home message of my presentation is this: management of acute chemical injuries significantly reduce the subsequent hidden damages. Like first of all, we should get rid of all the limes, then amniotic membrane to reduce the inflammation that further reduces scarrings. And we should protect the limbal stem cell, protect the raw surface and reduce symblepharon formation. The allocelate to promote epithelialization and reduce inflammation and symblepharon. The tenoplasty to handle the anterior segment ischemia. So, it is said that prevention is always better than cure. So, in such cases, we can prevent it by just ban all these means the lime pouches and the carbide guns should be banned. So, government should take action regarding this. So, thank you so much for this opportunity, and thank you so much for the patient listening. Thank you.
Thank you, Dr. Gautam, for such a comprehensive case-based cases shown by you and highly relatable. We had overcome this carbide gun episode, and your cases were so wonderful, and we could relate with those. Thank you so much. For discussion, we have Dr. Ankit Deokar and Dr. Bharti Ahuja. Would you like to discuss something, Dr. Bharti? Are you there?
Am I audible?
Yes, you are audible, Dr. Bharti, please. Yes.
First of all, I would like to congratulate Gautam sir for the wonderful talk, and it's always been a pleasure to hear your cases. And I would like to ask, sir, you have used in the first case, you have removed the lime plaque from the deeper layers of the cornea, and you have used, you did the DSEC. So what was the presentation means? When did the patient present it to you, whether it's in acute state or
very late? Yeah, no, patient presented in late. Acute stage was managed somewhere else, and patient presented after, I think, 3-4 months later to us with such scenario. So instead of doing penetrating procedure, I because I have seen and even in it was evident on the anterior segment OCT also that the lime is mostly impacted to deeper layers. The anterior half of the cornea is almost clear, especially in the central part. So then I thought about this approach, and this worked well.
You managed the case very nicely, sir. It gave me also an inspiration to manage my cases, and now I would like to see my cases also through that perspective.
Yeah,
thank you very much.
Because PK is always means chemical injury are the higher risk cases for penetrating procedures, and even the surface could be damaged more. And as in such type of cases where we minimally intervene the surface, so that's why these cases are preferable for the anterior means the surface injuries.
Yes.
Very correct. Dr. Ankit, do you want to add something?
Yes, ma'am. Nice presentation, Dr. Parmar, sir. And just want to add that it's very important to look for that there is any residue of chemical, like either a acid or alkali under the in the supratarsal or the infratarsal area as well. So eversion of fluid is really important in such cases, and we need to look for any such kind of residues whenever the patient comes to us. And just not only mere washing would help, but you should always avert the lids and look for that whether there is any other further acid or alkali residue being left over there, which might be causing a continuous insult, even if we try to put the patient on various drops to control the inflammation.
Thank you. Very correct, Dr. Ankit. Under the eye examination, the lid examination is very, very important. We have with us Dr. Shakeen, sir. Dr. Shakeen, would you like to add something?
Exactly. Very wonderful presentation, what has been shared. It's interesting cases. Am I audible?
Yeah. Hi, Shakeen.
Yes, sir, you're audible. Yes.
So all these patients with a chemical injury, we need a very close and regular follow-up, number one, as he has already mentioned. Then AMG, SLET, and CLET are of great help. So when we talk of the hidden injuries, going away from the chemical, only day before yesterday, I had a patient with a trivial injury that's in a foreign body, conjunctival foreign body is supposed to be. So my resident came down to me that, sir, he has a conjunctival foreign body. If you say I can remove it. So going back to the history, I got it when he was working with a chisel and a hammer. So we took that patient to the main OT and we removed the foreign body, small foreign body. But after removing the foreign body, we could examine there was a approximately 90% cut in the sclera. Though that patient was already screened well by the retina person and it is already mentioned that patient has a commercial retina inside. So what I mean to say, all these injuries, we need to be very careful for examination, preoperative analysis, and well explained to the patients. And be very careful when you operate, and even the trivial injury, we should be taking it seriously. And for the chemical, as it's been really covered very well, all the aspects. So CLAT, SLAT, AMG are of great help, and definitely the regular follow-up of all these patients. Of course, we need to be careful for glaucoma.
Very true, sir. Very true. Dr. Shushank is also with
Very
us.
true.
Shushank, would you like to add something? Dr. Shushank Bhalerao?
Uh, Dr. Shweta, I would like to add one thing
Can
after
Yes,
I
sir.
add
Dr.
Yes, sir,
something,
Shashank.
please.
Shweta?
Please, please, sir, please.
So very nice talk, sir. Gautam Singh Parmar, sir. Very nice. You covered so many cases of chemical injuries and showed hidden things. So just one thing like long-term effects or any residual tuna or lime should be removed, and we should clean the lime or any foreign body from the as much as possible. That one point. Second thing, as you correctly mentioned, prevention is always better than cure. So with the help of all legislative bodies, we all should work together to ban these kind of things like tuna packets and carbide guns. Definitely that will really help. So always prevention is better than cure. Apart from that, nothing from my side. Great talk, bro. Thank you.
Yes, sir, yes, you wanted to add about the PIL, something? We are working on carbide gun injuries.
Yes.
Not the PIL, but I would like to discuss about. We had worked with National Human Rights Commission, and we had success. We have been successful in getting it mentioned over the tuna packet that it should stay away from the children below 18 years, and because this is a very common factor all over the country, that tuna is used for tobacco and it is mixed with tobacco and it is placed anywhere, and it is in access with the children which are unaware of the consequences, and they get as rightly said by Dr. Gautam, and it is the initiative of the on the initiative of Ocular Trauma Society of India along with the National Human Rights Commission, we could do it, and we are working hard to avoid, to prevent other trauma also, like road traffic accidents, firecracker injuries, and we have written it to our chief minister and our state health minister on the consequences which the blindness in a lot of patients in our MP state due to the carbide gun injury. Dr. Mohan Rajan is also here. Dr. Rajan is also here. So we are very, very, and Dr. Grovers is also here, Dr. Shakeen, Dr. Mehul. We are documenting things and presenting it to the court of law, and trying to convince them that there should be a restriction on free availability of these things in our country, and there should be a special mention for the careful use of the sports things and sharp objects by the children, and prevention, as has been rightly said, is very, very important in ophthalmic trauma.
Very correct, sir. And your
Thank you.
hard work being visible, and under your leadership, Ocular Trauma Society and MPSOS is doing wonderful jobs. Congratulations to you, sir,
Can I
and
make a
thank you.
comment, Shweta?
Yes, sir. Yes, sir, Rajan, sir,
A
please.
very
Yes,
nice
sir.
presentation by Gautam. And also, as Purendra was rightly telling, we were also discussing during the AOS Jaipur that the AOS, okay, should work with the Ocular Trauma Society of India to bring about this implementation of this all these advocacies. The problem is we're not able to implement the laser guns, the prevention of laser guns, the carbide guns, and also the tuna packets and other things. So many other things, we need to make sure that whatever we are trying to advocate, and we get this thing, make it effective, and the implementation execute that to the so that it reaches the public. and prevention is better than cure. And also, I would like to tell Gautam, the message across we should tell every general ophthalmologist when they have an acute chemical injury, treat the acute phase very aggressively. Okay, because everything depends on that. All the sequelae depends on whatever is saying. If you treat the acute phase very aggressively with all sorts of measures, then the sequelae of this injury, whether it's an alkali or an acid injury or whatever it is, will become much less. We can reduce the implication of the whole injury to a large extent, depending on this thing. But if your acute phase is not managed properly, everything will get screwed up. I think this is a message because many people may not be able to manage whatever Gautam has done, but they can manage the acute phase and refer it to the tertiary center for the care.
Thank you so much, Rajan sir. Let's move on to the next talk by Dr. Ramakumar. He'll be speaking on posterior segment trauma, case-based approach to vitreoretinal injuries. And the discussants are Dr. Gajen Chawla sir, Dr. Tina Agarwal, and Dr. Himanshu Shukla.
Yeah, am I audible now?
Yes,
Yeah.
sir. Yes,
Hi,
you are.
Ram.
Sir, good evening, sir.
Hello, Ram.
Yes, sir. Good evening, everyone. I thank the outset Dr. Shweta, MPSOS, and the OTSI for giving me this opportunity. I think this is second time I'm presenting the posterior segment trauma in combination of OTSI and MPSOS. Some 12 years back, I had the opportunity in Ratlam, a physical meeting it was actually. So by definition, is it slide? Yeah, by definition, any trauma of the eye involving the segment behind the lens or a zone starting 2 millimeters behind the limbus is considered to be a posterior segment trauma. And we classify between closed globe injury and open globe injury, and we have many things which I'll be enumerating and giving examples in my subsequent slides. I try to avoid videos because I was given a time of 8 minutes for posterior segment trauma, so I'll see what whether I can do justice for this. Closed globe injuries start with Berlin's edema, which is something where we do come across a lot, and commercial retina involves large part of the retina without macular involvement, but Berlin's edema is like classically mainly macular involvement associated with diminution of vision when fovea is involved, but no active intervention is required. I just want to mention this point. Maybe we may add, but if at all there is associated inflammation, then give steroids. Otherwise, simple NSAID should be fine. And the 90% of cases they resolve without sequelae or even residual vision loss. Some of them they may, because depending on the severity of the injury, there may be a formation of a macular hole later on. But as such, most of the cases they resolve without any sequelae. So this is one thing one should remember. And the second thing will be kind of I think anyone can guess it, the ruptures which we see with blunt injuries. So choroidal tear or rupture is usually concentric to the margin of the optic disc. In the pictures that I had shown before, these things were not showing because they were all masked by the hemorrhages, and also there is a whitening of the retina over there, so you could not see the choroidal ruptures, but they are usually concentrated to the margin of the optic disc. And irreversible vision loss occurs only if the tear passes under the fovea. The tear per se doesn't cause irreversible vision loss. If at all it is, even if it is passing under the fovea, no treatment is required for the rupture per se, but it may result in CNVM later. The CNVMs I have seen as early as within 1 month, developing within 1 month after the choroidal rupture. So one should be aware about this possibility, and that needs a prompt treatment. And these are the CNVMs that resolve very well with treatment, unlike the irritating AMD cases. So this is one patient where this choroidal tear was passing temporal to the fovea. As you can see, it is parallel to the margin of the disc. And as I just took that option of wait and watch for the hemorrhage to clear, because I I thought it is not that thick enough for me to intervene with gas and TPA injection. So over a period of time that resolved, and you can see a rupture clearly temporal to the fovea, and the hemorrhage cleared, and the patient gained 6.6. So if it is not passing under the fovea, then you are not going to lose anything, just that you are seeing something. So in cases where acute cases where you're seeing a vitreous hemorrhage, and here also you can find there is a choroidal rupture which has happened, which is concentric to the disc here. And the next thing that we come across are like retinal breaks and associated detachments. So the blunt trauma causing these things. So most like these are like either dialysis, tears, or breaks. And dialysis are like detachment of the retina from the like at the ora serrata. So it is most commonly seen either in supranasal quadrant and temporal quadrant, and most common we are encountering with either ball injuries or fist injuries, and it may or may not be associated with the classic 7 rings of closed lobe injury. If we do based on the situation, either a laser, cryo, buckling, or vitrectomy. Main important is whether there is an associated retinal detachment. So that there are formation of tears or breaks, especially later, because PVD is something which can happen after a trauma, blunt trauma. So the horseshoe tears are definitely seen, and they are more common. But ruptured tears, I did operate, especially in the mid periphery. You see entire retina is retracted and a large tear exposing the choroid. These kind of things that I tried to operate these cases, but somehow they don't do well. These kind of ruptured tears, I don't know the experience of others, but literature also says they're not that good to treat. And yes, as with any case of detachment, we take the decisions about surgery. One thing I would like to mention here is we should not wait for hemorrhage to clear if the lack of media clarity is preventing proper laser or cryo. Just go ahead and do the vitrectomy and finish off treating these things, because after that the PVR and the contraction is difficult to treat. So earlier the better. So that's what I feel. If at all you have a suspicion, strong suspicion, or if you are seeing a break but you are unable to do the cryo or laser because the visibility is poor, then just try to go ahead and do vitrectomy. So this is like intraocular hemorrhages can be anywhere. So this is one sub RP actually. And we may see hyphema, vitreous hemorrhage, pre-retinal, retinal, subretinal, sub-RP, and yes, hemorrhagic choroidal detachment. The hemorrhagic choroidal detachment of trauma is little different from the choroidals which we see during cataract surgery, because the choroidals of cataract surgery, they are limited by the vortex veins, but the hemorrhage of the trauma, it's mostly seen posteriorly. So the thickening of the posterior choroid is something more suggestive of a trauma. And definitely B scan is invaluable in assessment or monitoring. And whenever you are seeing any non-clearing vitreous hemorrhage, then go for a vitrectomy. And this is for vitreous hemorrhages that I am saying. And early surgery, if it is associated with on B scan, if you are seeing any retinal detachment or intraocular foreign body, if there is any endophthalmitis, then definitely early surgery is required. And for hemorrhagic choroidal detachments, we do start with steroids and weekly monitoring of vision and B scan. And whenever the liquefaction is seen and if the kissing choroidals are there, then go for drainage, external drainage. And if it is no PL, yeah, maybe there may be some instances where we may think about evisceration if to avoid absolute glaucoma. So these are the kissing choroidals on a B scan. And you may see displaced intraocular lens or displaced natural lenses, and with or without cataract. I just wanted to mention one patient came with a dislocated IVL second time. First time it was injury with his grandchild's fist, and second time I fixed the IVL in the sulcus. I just removed it and put it in the sulcus because it was stable. I just left it, and 3 months or 4 months later, he went for some haircut, and the barber was doing some massage, and he tried to massage the eyes also, and the lens got dislocated again. There was no other go. I had to remove that and put an iris to IOL afterwards. So certain vague kind of traumas are also there, which may result in these kind of dislocations. And Yes, not just blunt trauma, even a penetrating trauma. You can see in this case an injury with a thorn, and though sterile, you could see a dislocated cataract, posterior dislocated cataract. So pars plana surgery, especially whenever it is posteriorly dislocated, go for a pars plana vitrectomy. And the timing of surgery is like, if other associated things are not there, then wait at least 2 to 3 weeks or even a month before going for this, because it's not an emergency until unless if there is a three-piece IOL, which is or a broken kind of a haptic or optic, and scratching the retina kind of thing is happening, then you may have to have to remove it fast. So as with any dislocated cataract, fragmentoma or cutter, depending on the hardness, and I will almost always remove through limbal incision. I prefer that, and because they say up to 5 mm of pars plana incision is good enough to remove, but whenever it is possible, try to remove through limbal incision. Don't extend the sclerotomies. Try to avoid maximum possible. And choice is yours based on the iris health and your choice. You can go for either a scleral fixated IOL or a posterior iris fixated claw lenses also. And other manifestations of closed globe injury, we do see a traumatic macular hole. This is one thing where we can wait up to a month. Even there are suggestions of waiting up to 3 months for spontaneous closure. I had good experience of waiting and getting spontaneous closures in at least 8 cases in my experience. And even after waiting a month, if you are not seeing, then go for a surgery. As with any idiopathic macular hole, the prognosis is usually poor, not just because even if the hole closes, because the surrounding RP degeneration is something which is associated with the trauma, is something which is disheartening. And because you may not be able to appreciate that when you are operating, or when you have taken a decision to operate, but it is something which happens almost 6 months down the line, and there you find that your result of the surgery is because of that RP degeneration. And retinitis clopetoria is some kind of a blunt injury, which is not an open globe but associated with a missile or a bullet passing in the orbit without touching the globe. They say it is classically described with bullet, but it can occur with any closed globe injury. It is a chorioretinal atrophy with strong adhesion and poor prognosis if the fovea is involved. So this is how we see this kind of scleropeteria kind of. This is not just scleropeteria, but yeah, something akin to that. So coming to the open globe injuries, the most dreaded thing being endophthalmitis. In Indian scenario, we are seeing bacterial and fungal both, but fungal is also possible with vegetative trauma kind of thing, and more common with trauma with biologic objects. And I have come across many cases with metallic foreign bodies also, and it needs early intervention, because endophthalmitis, as all of us are aware, we can still do a primary wound repair if someone is seeing an endo and there is a delay in referring. Still try doing a primary wound repair if PL is present. And I prefer, even the literature also recommends, and reviews of open globe injuries and traumatic endophthalmitis recommend injecting intraocular antibiotics for prevention of endophthalmitis during primary repair if you are suspecting contamination. So better to consider giving these injections during the primary repair, even if you are not seeing at that particular moment any kind of a signs of infection. And prognosis depends on individual case scenario, depending on the extent of injury and the organism virulence and all other things. Yes, definitely fungal endophthalmitis carries poor prognosis. So these are the guidelines for suspected endophthalmitis: primary wound repair with intravitreal antibiotics, referral to retina surgeon as early as possible, and confirmed endophthalmitis, immediate referral, and PL absent, then go for a evisceration and after explaining. So the flying objects, these are like foreign bodies you may find anywhere on the eye, on the surface, on the cornea, or even this kind of a, somehow the pointed thing is exposed outside in this thorn, and the larger part, the end is on the inside. Weird kind of injuries we can come across. and you can see a track starting from the cornea, iris, lens, and then going behind, and or it may get just lodged in the lens, or it may go all the way behind and penetrate the retina, go to the choroid. And this was the foreign body which was like kind of perforating injury. There used to be a classification where penetrating and perforating used to be there. So this crossed the sclera also. So these kind of things we may come across. So as already mentioned in the orbital foreign body presentation, non-biologic and biologic foreign bodies are there, and biologic are almost always reactive, and non-biologic, there are reactive and non-reactive ones. So reactive and biologic foreign bodies always need removal. Non-reactive foreign bodies need to be removed if there is a mechanical trauma noticed or anticipated. So clinical examination, photographic documentation, plain X-ray, ultrasonography. Ultrasound, even if you are doing a CT scan, certain times you may feel like doing, especially if it is like associated pathology like retinal detachment, which may not be appreciated on CT scan. So though CT scan is the preferred modality, whenever possible, if it is possible, doing gentle without causing much damage, try to do ultrasonography also to get more information to plan your surgery. So as whenever you are seeing a foreign body, as early as possible, like even during primary repair also, I prefer removing these foreign bodies. And I do wait for CT scan reports before contemplating primary repair if I'm suspecting a foreign body. And external methods of removal are I think not being done much. Orbital surgeons, they do it, but until unless it is not accessible internally, I usually prefer going for internal removal. As I already mentioned, don't extend any pars plana, any pars plana incision by more than 5 millimeters sclerotomy extension. And if it is anything more than that, sacrifice the lens or even the IOL. Even if it is IOL inside, I prefer sacrificing that to remove the foreign body rather than extending the pars plana incision, because they may look good in the immediate post-op period or even up to 3 months or 6 months, but long-term follow-up is bad, and they almost always go into phthisis. So this is where any retina surgeon listening to my presentation will understand why this foreign body after removal, you can see this area is all okay, but here there is a lot of laser marks and all. So I struggled a lot lifting this from the retina, and thankfully it didn't damage the macula, but a lot of area got touched by that, and I had to barrage that. So one more thing is a hypotony maculopathy in open globe injuries. So one should be aware about whenever you're seeing this kind of a picture in the posterior pole, you should and the eye is feeling soft, there should be some kind of a open globe somewhere, hidden or occult open globe injury. So one should look for that and consider exploration under the conjunctiva in all the quadrants, and then whenever you find it, try to repair that. And you may see a vitreous incarceration or a stalk which needs trimming, and certain times you may need to remove the underlying choroid along with the stalk and then do the surgery. So the last part of this is a sympathetic ophthalmitis. Any open globe injury, including any intraocular surgery, may be the cause. Within 2 weeks, it is like if you are seeing something in the other eye, don't consider sympathetic ophthalmitis. Something else may be there. 80 to 90% of the cases, they happen within 3 months to 1 year, and after 1 year, it is rare but still can occur. So any form of uveitis, either in this eye or the other eye after trauma or surgery, should arouse the suspicion of a sympathetic ophthalmitis. So one should be very well aware of this. And I don't know, lately I'm seeing many, especially the oculoplastic surgeons, even very late, even after a long time after the trauma, they still advise going for an enucleation with the fear of sympathetic ophthalmitis in the other eye. I have seen someone advising even after 1 year also. I don't know. I feel there is limited role of prophylactic enucleation. If it is PL absent, then it's okay, but otherwise better try to salvage it whenever possible, because we don't know how much vision is going to get preserved, and later on it may be of use for the patient in later life. So I feel prophylactic enucleation is something which is highly debatable. So good response to IVMP and immunosuppressants, and earlier the better if you start the immunosuppressants, and definitely for those steroid dependent or intolerant, you can go for immunosuppressants for treatment of sympathetic ophthalmitis. I think I'll skip this story of sympathetic ophthalmitis, and I think my presentation is done. So anticipation and proper evaluation for the anticipated diagnosis is the key in management of posterior segment trauma. And in cases with no view of fundus, ultrasound, B scan and CT scan, I would like to mention, be careful about B scan, because you may be causing further damage or pushing the contents of the globe out if there is an occult injury. So one should be careful about this possibility while doing ultrasound in suspected open globe injuries. And knowledge about timing and type of intervention and also about prognosis is required to consult the patient before treating and also before referring. Thank you.
Thank you, Dr. Ram Kumar, for a very insightful and practical overview of vitreoretinal injuries. Thank you so much. Do we have Dr. Gajen Chawla and Dr. Tina Agarwal? Can we have your insights? Dr. Tina Agarwal, yes, please. Please, you're muted. Please unmute yourself. Dr. Tina, unmute yourself.
Hello, I am audible?
Yeah.
Yes, you're audible, please.
Yeah, thank you, Rama. Very precise and comprehensive presentation. You covered most of it. I just want to share a few of my experiences. Like in trauma cases, what I had seen, the most important thing, whatever junior consultants do, they are not able to differentiate between the open globe and closed globe injuries. So if a patient is presenting with the 360-degree subconjunctival hemorrhage and even the intraocular pressure is normal, you should think about it could be a globe rupture, and you should think about it and go for a wound exploration if required. Second thing I had seen, even closed globe injury patient, if there is a blunt trauma patient and patient is having a very much periocular edema inflammation, patient come with a few subconjunctival hemorrhage and a vitreous hemorrhage, and there is a yellow reflex, and they confuse it with the endophthalmitis. So that is another reason, because many times in on ultrasound examination you cannot differentiate with the vitreous ecos, like what is the difference. So that is the another point. And regarding the sympathetic ophthalmia, many times because the patients are one-eyed and patient is so demanding, I had seen a good result with the Ozudex also with the early recovery. So thank you very much. It was a very nice talk.
Thank you.
Thank you, Dr. Tina. Dr.
Can I
Gajen
make a
sir?
comment, Sweta?
Yes, Rajan sir.
I think that was a master class from Ram. Ram really very enlightening. Only thing is, in rupture globe, trauma is the only case wherein even no PL will operate. Yeah. I'll tell you, recently I had a patient referred to me all the way from Coimbatore. He had a cracker injury, small child, about 8 or 9 years old, and he was having panophthalmitis. So he went to Aravind Coimbatore, they advised evisceration. He came to me with a lot of hope. Then I treated him, I explained the prognosis. He had no PL. I explained the prognosis and treated him with antibiotics and followed by steroids as well. Got the swelling down completely. Then he had a what do you call a rupture globe. Then we did a PK with a combined approach with the vitrectomy, settled the retina, suture the sclera as well. Now he's got hand movements close to face in that eye.
Children, yes, sir, we do.
Yes.
Don't depend on the response of PL. We always give the benefit of doubt to the patient and try to salvage as much as possible and do whatever best possible, even if PL is not given by the child. Yeah, most of the times we don't depend on that for children. But in adults, yes, we are seeing, because the expectations and all other things are different. And yes, we have seen adults sound mental health. I think they do give good response. So that way we don't give much of chance for the adults if it is a confirmed absent PL checked by individual separate practitioners. So I think that's what I follow.
Thank you
Very
so much.
nice.
Yes, Gajen sir, you wanted to say something,
Yeah,
please?
yes. What I agree with Dr. Mohan sir here, because when I was doing fellowship almost 30 years now, 35 years now, we had a patient in Shankar Netralaya. Patient was referred after this Calcutta blast in 92, 93. One eye lost, other eye was also badly injured. And first consultant in Shankaracharyya says evisceration. There was a rule you have to take a second opinion, second consultant opinion.
Yes.
Second consultant also said evisceration. But patient attendant said, sir, kuch kariye. I remember I was posted with Dr. Tarun Sharma sir. He says, okay, we do a primary repair under less than 1% prognosis. After that, luckily that I survived. And after 2-3 months, we did a vitrectomy with 360-degree retinectomy and this therapeutic PK and then optical PK. It took 6 months. That patient got 5/60 vision after 6-7 months. After that, it is a rule in my opinion कि yes, we should give a primary repair. आग तो कभी भी निकाल लेंगे जब निकालनी होगी. So I do that. I agree with Dr. Mohan Rajan here.
Very
But Ram, it was a wonderful presentation overall, and in such a short time, you have covered so many things. One or two things which I would like to add in that: if suppose there is a glove injury, there is a closed glove injury, there is no vitreous hemorrhage. When you are examining for dialysis or any peripheral break, we should do re-examine after 1 month, 3 to 4 weeks. Because after at that time also, maybe immediately after injury, there may not be a dialysis or a break. But after 3-4 weeks, when there is a changes in the vitreous base, probably that might create another that time can be the dialysis or break can appear. So one has to re-examine after 3 to 4.
Yes, sir. PVD can happen
Weeks after
also.
that.
PVD also can happen in that period. So one should be
Very
aware
careful
about
about that. And one thing which I wanted, what you do or other people do, if there is a vitreous hemorrhage, no RD after the injury. How much time you will wait for performing a surgery in that case?
What?
If vitreous hemorrhage, no view, B scan, no RD. Now, how much time you are waiting for performing a vitrectomy surgery? You wait for 4 weeks, 6 weeks, 3 weeks. What is your
Sir, if the patient is willing for say weekly or 10 days follow-up every 10 days for serial ultrasounds, I am not having the fundus view, then I prefer waiting for at least 1 to 3 months also. But if the patient is not willing for a regular follow-up, then I prefer going for a early surgery, because nowadays we have very good vitrectomy surgery equipment with us. So we can always go for it, but I prefer waiting if there is no RD or end of or
Can I add to it?
Yeah.
Yes, sir.
Yes,
So
please.
it all depends upon, in a case of a vitreous hemorrhage, whether it is in a setting of a blunt injury or a perforating injury. If it is a perforating injury, you do a B scan, you wait for the PVD to happen, and within 7 to 10 days, you are supposed to do vitreous surgery, because the scleral trauma will lead to fibrous ingrowth and inoperable RDs in a very short time. If it is a blunt injury, fine, depending upon the amount of vitreous hemorrhage. If you do a serial B scan every 7 to 10 days, if there is no detachment and if you feel the hemorrhage is going to clear, well, you can wait up to 6 to 8 weeks. But if it is quite dense in nature, which is not letting you have a proper look at the retina to evaluate whether there is any break you are suspecting beneath it, there is nothing wrong in doing as early as 4 to 5, even 7 to 10 days later, I should say, once we have a PVD. So serial B scans is mandatory. So you need to repeat a B scan every 7 days and be sure. So for the sake of audience, single B scan is not the way to manage a case of a trauma. It's always in a dynamics. It's always the internal things are constantly changing. So you need to do a serial B scan whenever you don't have any media, proper view of the posterior state. And regarding no PL perception, I firmly feel that every patient, irrespective of his age, should be given a benefit of repair or reconstructive surgery, and enucleation or evisceration is never a first line of treatment in however badly mutilated eye it is. That is the
Yes.
dictum now, which even the trauma societies across are mentioning.
Absolutely.
I want to have the opinion of the plastic surgeons here.
Yeah. So if we do the evisceration immediately, so that outcome are not as good as that means. So if we can wait, we can wait. And there's a rule of the thumb. We don't know what happened. So each and every patient should get they should treat by the primary repair at least and the serial ultrasound. Even lots of PL negative cases also, they may gain up to 660, 636 vision depending on the stages. So whatever way till tricycle also we can properly you can implant the ball, no issue. So there should not be any hurry. And second, in my opinion, is that if we do the surgery immediately, visualization enucleation is a very, very painful for the patient as well as the parents or the party. That's why if we can wait, patient can accept psychologically, even in very badly disorganized eye also, generally I wait and just inform them about the sympathetic ophthalmia for a periodic checkup. So for psychological point of view, it is very, very good if we can that do after 1 year, 6 months even.
I think sympathetic ophthalmia is too much hyped thing. And in
Yeah.
today's era, with a proper immunosuppressive, steroids, immunosuppressives,
There
and
is
better
no,
understanding, I
yeah.
don't think we ever lose the other eye. So
Exactly.
I
You
think
are
we should
very
never
correct.
ever enucleate for the fear of sympathetic ophthalmia.
Yeah.
Very good.
So I
I
think
would like to
And
add
the
something.
recent
let me
dictum also says
say
that
something.
medical legal.
Yes, Purin sir.
Yes, sir. Yes, sir. Dr. Grover, sir, please.
I think I agree with the discussion that primary enucleation or evisceration is virtually never considered now, as long as the eye can be put back in any way. Because there are instances where recovery of some kind can be made in these cases wherever a primary repair is done. So the first principle is to put the globe together. And I also agree with the surgery for no PL cases, because there are now published series as well which show that perception of light can be a fallacious sign at the for evaluation for later VR surgery, and results can sometimes be quite dramatic, as has been pointed out in some isolated instances, and there are series that support it. There are publications that support the use of VR surgery in no PL cases. And where the surgery is to be done, a destructive procedure, so-called destructive procedure, enucleation is preferable, even though the risk of sympathetic ophthalmia is now negligible. But the principle would be to get rid of the uveal tissue, if at all the eye is to be removed. Then it should be an enucleation at the primary stage rather than an evisceration.
Very good. So with this, we come to the end of this webinar, and I must say we all had a great academic feast for today's dinner. And I must congratulate everyone, and it has been a wonderful blend of experience, evidence, and practical wisdom. And on behalf of MP State Ophthalmic Society and Ocular Trauma Society, I extend my sincere thanks to all the speakers, Dr. Nikunj Tank, Dr. Kamal Preet, Dr. Gautam Parmar, Dr. Ramakumar, and our senior panelist, Dr. Ashok Grover sir, Dr. Mohan Rajan sir, Dr. Natarajan sir, Dr. Prashant Babankule sir, Dr. Puren Basin sir, Dr. Shakeen sir, Dr. Mehul, Dr. Jayanta, for their insightful take-home messages. I'm also thankful to the discussants, Dr. Pawan Sthapak sir, Dr. Vinita Ramnani, Dr. Prabha Gupta, Dr. Deepak Soni, Dr. Ankit Devkar, Dr. Bharti Ahuja, Dr. Jane Chawla, and Dr. Tina Agarwal for discussing the the talks very nicely and coming up with excellent discussion today. I'm also thankful to the Clarnet for providing us this platform, and I think it has been a wonderful initiative of our president, Dr. Puren Basin sir, for starting this collaborative meetings in the zones. And thank you everyone for joining. And I think everyone had a lot of learning and take-home messages, and everyone is motivated to do something new from tomorrow. Thank you, everyone. And if anyone wants to add something, you're most welcome, please.
Thank you. Thank you very much.
Thank you. Thank you,
Thank
Shweta.
you, everyone.
It was wonderful.
Thank you.
Thank you.
Thank you, everyone. Thank you, everyone.
Very nice. Very
Congrats,
nice presentations
Purendra.
and good discussions.
Purendra, congrats, and Shweta.
Congratulations to Purendra
Well
and
done,
team.
well done, well done.
And congratulations to
Thank
Dr.
you. Thank you,
I
sir.
think it's a great
Thank you.
initiative.
Thank you. Let us do it.
Yes.
I think we have seen the most dynamic president of the OTSI ever. Purendra Basan. Thank you.
Very good.